This is a common clinical presentation of severe anterior segment inflammation, what most patients simply call a red eye. Because this presentation is so ubiquitous, standard protocol often defaults to a conservative regimen: warm compresses, topical lubricants, and a period of observation. However, this visual state represents a dangerous ambiguity. It could belong to one of two vascular conditions that appear nearly identical to the naked eye. If the underlying pathology is the more severe of the two, treating it as a minor inflammation can lead to devastating, irreversible tissue loss. Surface-level observation is an insufficient diagnostic tool for ocular inflammation. To determine the risk, we have to look deeper into the physical architecture of the globe. Episcleritis is a highly localized, relatively benign condition. It is essentially an anatomical inconvenience that frequently resolves without significant intervention. Scleritis, on the other hand, is a severe, tissue-destroying disease that actively compromises the structural integrity of the human eye. Unmanaged necrotizing scleritis is not merely an ocular issue. It carries a mortality rate approaching 25% over 5 years, usually due to complications of an underlying systemic disease. The primary clinical mandate is to chemically isolate the true depth of the inflammation before tissue destruction begins. Differentiating these conditions requires mapping the eye's 3 distinct vascular strata from first principles and applying a targeted pharmacological stress test. The foundational structural layer of the globe is the deep sclera, composed of dense, irregular collagen fibers with minimal inherent blood supply. Resting immediately on top of that collagen is the deep episcleral plexus. This is a fixed, immobile network of vessels that provides the primary nutritional supply to the scleral stroma. Layered above that is the superficial episcleral plexus. These vessels arrange themselves in a distinct radiating pattern and maintain a slight degree of physical mobility over the deeper structures. Separating these episcleral vessels from the surface is Tennant's capsule. This translucent fascial membrane encases the globe and acts as a critical anatomical barrier. Sitting entirely outside that fascial barrier is the conjunctival plexus, a chaotic, freely mobile vascular network on the absolute surface of the eye. Inflammation can originate from any one of these 3 distinct vascular beds. Under a standard slit lamp, these distinct layers visually compress, making the engorged vessels appear as a single, indistinguishable red mass. Precise diagnosis is impossible without a methodology to conceptually and practically separate these strata. Episcleritis presents as a localized, wedge-shaped area of hyperemia in the interpalpebral region, with the apex of the wedge pointing toward the limbus. The color is typically a bright salmon pink hue, identifying the inflammation as a flare-up of the superficial plexus. Scleritis is generally more diffuse and lacks the distinct wedge-shaped boundaries seen in episcleral cases. In scleritis, the eye takes on a deep violaceous or purple hue. This color change is a result of optical physics. You are viewing the severe congestion of the deep plexus through the overlying, uninflamed layers of superficial tissue. The pain profiles are also distinct. Episcleritis causes mild tenderness, whereas scleritis involves excruciating, radiating pain that worsens during eye movement. This deep, boring pain occurs because inflammation in the deeper anatomical layers physically stretches the nerve endings embedded in the sclera. To confirm the diagnosis, clinicians employ a pharmacological stress test designed to strip away superficial clinical noise. Topical phenylephrine, at a concentration of 2.5 or 10%, acts as a powerful, fast-acting vasoconstrictor. Upon instillation, the drops are absorbed into the outermost conjunctival layer. Tennant's capsule acts as a physical barrier, trapping the vasoconstrictor in the upper layers and largely protecting the deep episcleral plexus from its effects. This results in the rapid constriction of the conjunctival and superficial episcleral vessels, causing the eye to blanch. A manual cotton bud test is often used simultaneously to check if the remaining visible vessels move freely with the conjunctiva or remain fixed to the sclera. The practitioner must wait 15 to 30 minutes after installation to accurately interpret the results. If the eye turns entirely white, the inflammation was isolated to the superficial layers above the fascial barrier, confirming episcleritis. If deep, engorged vessels remain visible, the phenylephrine has failed to affect the deep plexus, identifying the deeper source of the inflammation. The failure of the eye to blanch following phenylephrine instillation definitively confirms scleritis. A confirmation of scleritis requires the clinical focus to shift from the local anatomy of the eye to the patient's systemic health. The underlying pathology of severe scleritis involves circulating immune complexes that deposit in the vessel walls, causing aggressive granulomatous inflammation. This process is a type 3 hypersensitivity reaction, an immunological trigger for widespread vasculitis. This chart demonstrates the high correlation between scleritis and major connective tissue disorders like lupus and Wegener's granulomatosis. Rheumatoid arthritis is the most significant association, showing a high correlation with the necrotizing form of the disease. Scleritis in a patient with rheumatoid arthritis signals aggressive extra-articular vasculitis activity outside of the joints. In these cases, the eye acts as a visible alarm for a life-threatening systemic crisis. If this systemic signal is missed, the physical consequences for the globe are severe. The inflammation releases proteolytic enzymes that aggressively destroy the dense collagen fibers of the scleral stroma. This cellular destruction leads to progressive and severe scleral thinning over time. The distinct clinical sign of this loss is a bluish tinge, which occurs as the underlying uveal tissue becomes visible through the compromised sclera. Without intervention, this leads to staphyloma, where the thinned sclera bulges outward, creating high perforation risk. Episcleritis requires only supportive therapy, lubricants, or oral NSAIDs to manage symptoms. Scleritis demands immediate referral for systemic investigations and the administration of potent immunosuppressive agents. Isolating the deep episcleral plexus allows the identification of a condition linked to high mortality rates, turning an ophthalmic assessment into a vital systemic screen.